We're very pleased to have Dr. Gupta join us today. This was a suggestion made by one of our members. Postural orthostatic tachycardia syndrome is something that is quite prevalent amongst people with ME/CFS. Also fibromyalgia. I'm sure Dr. Gupta will talk to us a little bit about incidence. But it's one of those things that's actually, it is quite difficult to get some clear advice and guidance on and to get some good understanding. It's not something that GPs are very well versed in, and many people have had to do a huge amount of their own research to try and make sense of what's going on. So I think today's audience is likely to be a lot of people who have done a good amount of Google research and will be very pleased to hear things directly from a specialist in the field. So Dr. Gupta is a consultant cardiologist and heart specialist, works at York District Hospital. I think I'm going to hand over to Dr. Gupta then you've got some slides to share with us, and please keep those questions coming in as we go through the talk. So can I hand over to you, Dr. Gupta? A very, very warm welcome from all of us. We're delighted to have you.
Thank you so much. Thank you for having me. I really appreciate the fact that people have taken their time after lunch to join me. The good news here is that you're not going to lose. Either you'll find what I have to say interesting, or I'll bore you to sleep. And in my own experience, everyone can do with a bit more sleep. So, you can't lose. The first thing I'd like to say is I feel privileged to come and talk to you. And the reason I do so is because I think as a medical profession as a whole, we owe people with chronic fatigue syndrome and POTS and fibromyalgia, etc., an apology. For too long have we chosen to neglect patients and instead concentrate on what we know and what we've read in books. And my background is that I was trained as a general cardiologist. I wasn't someone who has any kind of level of expertise in POTS or chronic fatigue syndrome. And this is a very honest story. My first contact with any patient with POTS was about 7 or 8 years ago. And I recall going onto the ward, and there's that, the junior doctor says, yeah, we've got this lady who complains of her heart rate shooting up. She's got this funny thing called POTS. I don't know what that is. And I was like, she's got CFS. She's a bit mad. We'll just, that was what, and that is what I chose to believe at that time. The problem was that this patient kept coming back into hospital. And whilst the initial kind of my mindset at that time, my indoctrinated mindset was, well, this is just an inconvenience, this patient. I don't have anything to offer this patient. Increasingly, I started appreciating this lady for who she was. She was a very sensible person. She had ambitions. She had worked hard. And suddenly, her life had been turned upside down. And she had this multitude of symptoms. And whilst they didn't nicely fit in any kind of thing I had read, the reality was that this was a really genuine, kind person who had ambition, who had a supporting family, but she was going through this horrendous thing. And somewhere, no one was interested because everyone was sort of focusing in on their thing. When I go, okay, what's the cardiac thing? I'm not really, my mindset wasn't, who is this person? How do I help this person? My mindset was, which bit of her do I understand that I can do something with? And if it didn't fit nicely in a box, then somehow, rather than choose to think of her as think of me as a student needing to learn a bit more, I would think that there was a problem with her brain or something like that. As I got to know her, I started becoming really interested, and we started working together, and I started saying, well, I started really appreciating her for who she was. And slowly and gradually, I started meeting other people who had similar symptoms, and they were all saying the same things. And on the basis of that, I decided that I was going to try and educate myself over this condition. I was going to spend more time listening to patients rather than just listening to my colleagues or listening to books. And it became very apparent that there was something very real here. After that, I did a series of videos online, which seemed to resonate with people. And now I have about 400 patients that I look after with POTS, many of whom also have chronic fatigue syndrome. Many of them have fibromyalgia. And I think dealing with these patients has made me a better doctor. It's made me a kinder person. It's made me someone who has started understanding how important it is that we listen to our patients, and no matter whether things fit in nicely into boxes, our aim as doctors should be to deal with the patient in front of us. And it doesn't really matter. What we're there to do is to try and help that patient. And I never thought like that before. And for a lot of patients, it became very apparent that all they needed is just to feel supported. All they needed was someone there who said, look, I believe you. I don't think this is all in your head. I believe you, and I'm here to support you, and I'm here to try for you, and I'm here to come out of my comfort zone for you. And as long as you did that, they're the most satisfying patients to work with, far more satisfying than giving someone a statin or giving someone some aspirin. Here, we were actually being able to communicate, build a rapport, and you see this patient develop confidence and start feeling empowered. And when they do, and they send you a message saying, look, I've been able to stand up for the first time for my son's birthday in 8 years. I've been able to host a party today. That is far more satisfying than any other part of cardiology that I have done. So, it's a privilege to talk to you, because I have great admiration for the resilience that those patients who have these kind of invisible and poorly acknowledged conditions, because I really think it must be very hard. And to keep going with all the stresses that life throws us, and then just feel unwell and to live with this is incredibly tough. And I admire this resilience. I'm going to talk to you about POTS and what I know about POTS. Again, as I say, I'm no expert who has done a PhD in POTS. My experience comes from practical experience dealing with lots of patients, and many of whom are actually getting better. So I'll share my slides now, and then we can go through things. Let's have a look. Here we go. Okay, perfect. So I've termed this talk, POTS, a remarkable condition. And the reason I call it a remarkable condition is because it is remarkable in the sense that it generally tends to affect otherwise young, previously healthy, and often high-achieving people, people who were remarkable in some way before they became unwell. It is remarkable in the sense that it seems to affect so many different systems in the body. It is remarkable in how debilitating it is for the patient, and yet how invisible it is for the outsider, to the outsider. It is remarkable in how prevalent it is in our society, and yet how little recognition it gets from the medical profession. It is remarkable in that despite all the advances in technology, we still don't quite know why it happens and how we go about curing it. So let me just, play this. The first description of what we now recognize as POTS was made by the guy on the left, who is Da Costa. He was a surgeon in Philadelphia. And in 1871, he observed that in patients who were in soldiers who were being enlisted in the American Civil War, what would happen is that these soldiers, there were civilians really who had been enlisted in the war, and they were sent on long hours of marching. So they would be asked to walk up to 20 miles in a day at double quick pace with poor food, poor water supplies, and in bad weather. And what he started noticing is that a group of these soldiers would then develop a viral infection, and they would become exhausted and they would start falling out of line. And after that, they would be given some time off, they would recover from the infection, and when they returned to marching, they would never be able to quite achieve the levels that they were able to before they became sick. These patients would complain of fatigue, breathlessness, tiredness after mild exertion. And he also noted that when you measured their heart rates would tend to go up greatly in response to posture. So if they were lying down, their heart rates would be better. If they stood up, their heart rates would be much worse. And the guy on the right is a typical such soldier who's been described. So that is probably the first description of what we now recognize to be POTS. It was called the irritable heart of the soldier, or de Costa's syndrome. Now, the feature of POTS stands for postural orthostatic tachycardia syndrome. And by far the typical symptom is this idea of orthostatic intolerance. When the patient is upright, they don't like it. They don't like being upright for a prolonged period of time. That can be sitting or standing. And it is usually far worse and far more troublesome if the patient is still. So a lot of patients will say, I'm not too bad if I'm walking around, but if I stand still for any period of time, I really struggle. And they get a bunch of symptoms, but by far and away, the symptom that brought it to light and made cardiologists interested is the symptom of palpitation. These people complain of their heart rate racing, and often they complain of lightheadedness. They may also complain of chest discomfort and breathlessness, but by far and away, the thing that brought this cohort of patients to cardiology's attention was the fact that they complained of palpitations and lightheadedness when they were upstanding. When you then go in and ask these patients, they have a ton of other symptoms as well. And these symptoms are not necessarily always related to standing. They occur at all times. And in particular, all patients I have met with POTS will complain of extreme fatigue. They will complain of mental clouding, brain fog, difficulty carrying out cognitive tasks. It's like a cloud over their heads. They complain of headaches, they complain of tremulousness, they complain of blurring of the vision, they may complain of auditory disturbance. By virtually every single patient with POTS will complain of a disturbance in their sleep pattern, so they never wake up feeling refreshed. And they often have gastric symptoms and often carry a diagnosis of irritable bowel syndrome. I think there are a bunch of patients who have probably had all these symptoms for a long time, but because these symptoms tend to be a little bit non-specific, I don't sleep well, I'm tired, doctors didn't really take much interest in those symptoms. But the minute the patient said, look, I get heart palpitations, the doctor said, okay, well, why don't we send you to a cardiologist? And the cardiologist typically would disregard all the other symptoms and say, okay, you've got heart palpitations. When do you get the heart palpitations? When I stand up. Let's see what happens. So let's stand them up and see what happens. And lo and behold, they noticed that when these people stood up, their heart rates on most occasions would shoot up. And so the cardiologist would then say, yes, your heart rate does go up, but it's going up regularly. Let's give it a name, postural orthostatic tachycardia syndrome. You stand up, your heart rate goes up and you don't like it. And that's all POTS means. So POTS is not whilst we think of POTS as a diagnosis, it is actually just a fancy term for the fact that you don't like being stood up for a prolonged period of time and your heart rate goes up. The important thing to understand is there is no single patient that I have with POTS who will not complain of all these other non-cardiac symptoms. And the definition of POTS, the current definition of POTS, does not take into account all these other things. And that is really important. So at the moment, people say POTS is an increase in the heart rate of more than 30 beats per minute and more than 40 beats per minute if you're a child within 10 minutes of upstanding from a supine position. And they say you have to have this heart rate to extend for more than 30 seconds and ideally for the duration of the time. And they also say that at that point, your blood pressure shouldn't fall. So you maintain your blood pressure, but the heart rate shoots up and it stays there. And it's a frequent and chronic observation. That's fine. I appreciate that. But a much better term, because a term that will take into account everything else that that patient is enduring, is a dysautonomia. And this is the difference between POTS and a dysautonomia. A dysautonomia simply means a disturbance in autonomic nervous system activities. So when we think about this thing called the autonomic nervous system, we're thinking of this balance between our flight and fight systems and our rest and digest systems. And a disturbance in our flight and fight responses versus our rest and digest responses would be termed dysautonomia. If I go back to the symptoms, if you look at these are all flight or fight or rest and digest symptoms. You know, if you think that these people are tired, so they're not rested, they do not sleep well, they're not rested, they have gut symptoms, they're not digesting, they're getting heart rates high, flight, they're getting temperature disturbance, flight. So they're getting breathless, again, flight or fright. So that is a much better term of thinking of something as dysautonomia rather than POTS, because dysautonomia covers everything, whereas POTS just refers to this rise in heart rate. And the reason it is so important is because if you just rely on the definition of POTS, and for some reason the patient doesn't get that heart rate, then they're told they don't have POTS and you can go away, right? But if you think of this and if you ask the patient about these other symptoms, all these other symptoms, then you've made your diagnosis without needing any additional tests. If there is no other explanation and the patient says, I don't like being stood up for a prolonged period of time, and actually I never wake up feeling refreshed, and I never feel, and I have gut issues and I get brain fog, etc., and there's no alternative explanation and they've been struggling for a bunch of months or years, then this is the diagnosis and this is all I need to start saying that's what we have here. The problem is the purists now, and mistakenly so, say, well, if you don't have this, you don't have POTS. This is wrong. The patient comes first. Definitions come after that. And when you start asking patients about this, and when you start looking for it, you start finding that this is an epidemic. I am at this point in time getting 4 patients referred to me every day with these symptoms. When I send them for tilt table testing or looking for tests, some of them come back positive, some of them come back negative, but I treat them all based on my clinical assessment. And when I do, the majority start responding. So at this point in time, based around this current definition of POTS, people would say that up to 3 million people in the States have POTS. And generally the ages are between 15 and 50. And you see more women, but of course you do see it in men as well. And why does it happen? And we're not quite clear, but I have certainly observed in my patients that by far and away, most of them have some kind of genetic vulnerability. When I speak to them, you will often find during conversation that their mum or their aunt will have had similar symptoms. Maybe it was never formally diagnosed as that, but they've had similar symptoms. So there does appear to be a genetic vulnerability. And by far and away, virtually, I would say the majority of my patients will admit to having joint hypermobility syndrome or Ehlers-Danlos syndrome, joint hypermobility variant. So that is the genetic vulnerability. And the idea behind this particular condition, joint hypermobility, is that in a simplistic sense, and my understanding of this is only simplistic, is that they have much laxer blood vessels. So their blood vessels tend to be more lax. And in some way that contributes to how they respond to orthostasis. There's a genetic vulnerability, then something happens in their lives, and that could be pregnancy, glandular fever is very common, trauma, some kind of viral illness, some kind of major surgery, some kind of prolonged period of being bedbound, even extreme stress, something like that. Interestingly, some people have mentioned the HPV vaccine. I know that no one likes to talk about vaccine, but this is what people have said to me. And then after that, it is almost like they become ill and they never quite recover, a bit like what Da Costa described with his soldiers. They never quite recover. And then they have flare-ups. There are triggers which will cause flare-ups. So genetic vulnerability, something happens, an index event happens, the genie is let out, and then some things make the genie more prevalent in their lives, and others sort of calm things down. But the common triggers are dehydration, heat, alcohol, exercise, any form of intercurrent illness. And for all women, things are worse around their periods. Hormonal changes have a big role in how much more symptomatic they get with their symptoms. Now, I just wanted to, I had a bottle here. This is the physiology of standing up, because one of the things that we have to ask ourselves is, what is it about this orthostasis? Why are they orthostatically intolerant? And for that, we have to understand what the physiology of standing up is. This is what I describe to my patients. Again, simplistic. It may not necessarily meet every kind of physiologist viewpoint, but this is the simple way. So in general, if we think of a bottle, a half empty bottle, if we think of this as our brain here, and then this is the body, and the water in the bottle is the blood. When we're lying down, our brains are well perfused with our blood. When we stand up, gravity comes into the equation, and therefore the blood gets sucked down. And ordinarily, because our brains would go without blood, we would all collapse again. However, that doesn't happen because a couple of reflexes come into motion. The first is this surge of blood into our legs is detected by our leg vessels, and our leg vessels will constrict to try and keep the blood up. And the second thing that happens is we produce adrenaline to try and increase our heart rate to keep the blood going. And then we reach a steady state and we stay like that. Somewhere in those two actions, there is a fault in patients with POTS who are not able to maintain an orthostatic position. Either they don't squeeze as well, or for some reason, their adrenaline levels, the adrenaline levels that are produced are so high that their heart rate goes up excessively high. And because their heart rate's going up excessively high, the heart is working harder, but because it's not getting much time to fill with blood, you actually get less blood going around. And that may be the mechanism as to why people don't like being stood up. Either they're not compressing, either their leg vessels are not stretching. That is why Ehlers-Danlos and joint hypermobility may have a role to play, because they have lax vessels, and so maybe their leg vessels don't compress as well. And also the heart rate may be going up excessively high, and therefore you're not getting as effective a surge of blood to the brain. And that is why they probably get the symptoms. The reason I say this is because once we understand this, then we understand why some of the treatments that are prescribed work or help. But I'll talk to you about that in a second. Increasingly, as people have started becoming aware of POTS, they're trying to work out what the mechanisms are. And there is no one mechanism. The neurologists, if you go to the neurologist, because you see, the problem is POTS patients, some go to the neurologist, some go to a cardiologist, some go to someone else. So the patients who ended up with the neurologists, the patients who ended up with the cardiologists initially said, well, maybe these people just have less water in the bottle. Maybe that's the problem. And indeed, when you look patients with POTS do have reduced blood volume, and even in that volume, the cells that they have are smaller. So why is that? Why do they have less volume? For that, we have to understand what regulates volume in our bodies. And this is something called the renin-angiotensin system. These are a bunch of hormones secreted by the kidneys, which help us retain water. And in patients with hypovolemic POTS, these patients who are supposedly having less blood, the idea is that when you look at these hormones, for some reason, they don't produce the same magnitude of hormone in response to being dehydrated compared to other patients. So their renin and angiotensin levels seem to be abnormally low. And in addition, because the blood cells themselves are smaller, they're carrying less oxygen around. So there is some credence to this hypothesis that maybe in some people, they just have less water in the bottle, to start off with. Then the neurologists came up with a theory about neuropathic POTS. And again, so they were interested in looking and saying, well, maybe there is enough water in the bottle, but maybe you cannot squeeze adequately. That's why you're getting the problem. So they then started saying, well, let's study the nerves that control the squeezing effect in the legs. And they found that when they started doing biopsy, these people did have less sympathetic nerves in their legs. And maybe that was the thing, that they were unable to respond to this increase in blood volume in the legs by squeezing adequately, and therefore less blood was being pumped to the heart. And that became the hypothesis behind neuropathic POTS. So some people are told they have neuropathic POTS. Some people are told they have hypovolemic POTS. And then some people have this thing called central hyperadrenergic POTS, where they say, okay, what is happening here is perhaps in your case, you're just producing too much adrenaline. So remember, when we look at the way we're always in a nice kind of equilibrium between our flight and fight and our rest and digest systems. If you come, let's say you're lying there and I come and say, boo, I would activate your sympathetic system, I'd activate your flight or fight response, you would produce adrenaline. And after a little while, you'll get all the effects of that adrenaline, and then the adrenaline will die down and everything will go down. What we do know is that in dysautonomia, the pivot has moved this way. So a small trigger causes a huge surge. Now, the question is, why are we getting this huge surge in adrenaline? Is it that in some way we're producing too much adrenaline? Or is it that we're responding in a hyper-exaggerated fashion to the adrenaline we are producing? So we're producing normal levels of adrenaline and we're just responding in an exaggerated fashion, or are we truly producing more adrenaline? When we have looked, when researchers have looked, they have found that noradrenaline levels do tend to be higher, both lying down and standing in these patients. And actually, one of the manifestations in these patients is because they have the higher adrenaline, their blood pressure shoots up as well when they stand up. For some forms of POTS, the blood pressure doesn't go up, but there is a subgroup of patients with POTS in whom the blood pressure shoots up, the heart rate shoots up, and they actually will then say, I feel very tremulous, I'm very anxious, I get very cold. And those people are billed as having hyperadrenergic POTS. Some people have been found to have a problem with the receptor that clears the adrenaline. So you produce the adrenaline, maybe not as much adrenaline as maybe the same amount of adrenaline, but you cannot clear it because there's some kind of deficiency in the receptors that clear the adrenaline. So the adrenaline stays around for a lot longer. Then there is another group of patients who have something called mast cell activation. And I don't know whether many people know about this. I certainly didn't. And I'm sure that those of the viewers today who are educated in it may have a much more sophisticated understanding of this. But to my mind, the way I understand it is mast cell activation. Mast cells are cells which, for example, if I take my pen here and I draw it against my skin, what you will find is that my skin will become red and it will become indurated, it will become swollen because of the insult. And that reaction is carried out by mast cells. And the idea is that what happens is that the mast cells, through histamine, make our blood vessels around there more permeable. So everything leaks out to try and fight whatever the insulting agent. So that is the idea. So that's what mast cells do. There is a group of patients who have something called mast cell activation syndrome, in where what will happen is some kind of insult causes a ton of mast cell release. And what that huge surge in mast cells does is that it makes all our blood vessels leaky. So for that period of time, what happens is blood water leaks out of the bottle. And so these patients get these symptoms where their heart rate then shoots up, etc. The blood pressure goes, the heart rate shoots up, they get all the same symptoms. In these patients, a diagnosis is made by measuring these histamine metabolites in the urine. And these patients often get a flushing episode. So the hallmark of mast cell activation is that they often flush quite a lot. And these patients seem to respond with antihistamine. So these are the different subgroups of POTS. Another group of POTS patients are patients who have physical deconditioning. So that can also, physical deconditioning itself can also cause a POTS-like syndrome. The question is it just the physical deconditioning, or is it physical deconditioning in a patient with the genetic vulnerability, the pre-existing genetic vulnerability? But there's a guy called Benjamin Levine in America who did some really interesting research. And basically what he was interested in finding out was what are the physiological effects of deconditioning? If you take someone and lie them in bed for, and decondition them, what happens? So he studied the heart size of patients with POTS, and he found that on average, patients with POTS had a 16% smaller heart, smaller muscle mass compared to normal people. So they had smaller hearts. The amount of blood volume that was being circulated was between 13 and 20% less in patients with POTS. So smaller heart, less blood, and that could be another reason behind the symptoms that happen as a result of this lack of blood going to the brain. Interestingly, what he found was that if you then exercise these patients through a 3-month graded exercise protocol, you could actually increase their muscle mass back to about 12%. You could get a 12% increase in the mass of the heart and increase the blood volume by about 7% just through a graded exercise program. I'll talk to you about that later. And then there is this thing called autoimmune POTS, where people have said, well, maybe it's something about the virus. We react to the virus, we produce our antibodies, and perhaps these antibodies attack us in some way, and therefore inhibit how we would normally respond in terms of our autonomic functions to standing up. The reality is that whilst there are all these subtypes of POTS, in truth, they all overlap. And I practically never spend too much time looking for what type of POTS it is. I try and do the things that seem to work for the majority of patients. So people with POTS worry and they say, look, have I got the neuropathic type? Have I got the hyperadrenergic type? We don't quite know because there's considerable overlap. And I don't think it really makes a big difference to how we manage them, certainly how I manage them. But these are the kind of theories behind POTS and why it may have occurred. In terms of these, people say that the neuropathic POTS tends to be more common. It tends to occur very suddenly. The hyperadrenergic POTS comes on more gradually and tends to be associated with high blood pressure on standing. And the developmental type of POTS, which comes in puberty, because the bottle has become bigger during puberty, right? So the bottle is becoming bigger, so you've got the same amount. The idea with the patients who have a developmental type of POTS is that there is hope that as the patient gets older and they reach a steady state, the symptoms resolve. And we do see that as well. It's also important to say that a lot of patients with POTS have a bunch of other associated disorders. A lot of patients with POTS are told they have anxiety. Whether anxiety coexists or whether it is the fact that no one believes them that causes the poor patient the anxiety, which is completely understandable, I don't know. But yes, there is no doubt that a lot of patients who would come to me with symptoms of POTS will also carry a diagnosis of anxiety. And I would say about 40%, 30 to 40% of patients with chronic fatigue syndrome probably have POTS as well. And certainly whenever I see chronic fatigue syndrome, I'm always thinking, could this patient have POTS? So I would urge anyone with chronic fatigue syndrome to just think about that, because there are things that we can do with POTS which can make a difference to a person's quality of life. Deconditioning, depression, fibromyalgia, mitral valve prolapse, joint hypermobility syndrome, Raynaud's disease, irritable bowel syndrome, migraines. These are all things that I see very commonly in patients who have POTS. We also see things like secondary triggers, alcoholism, bed rest, diabetes, etc., which seem to contribute to patients developing more symptoms. But it's just interesting. So whenever I see fibromyalgia in a patient, and they've been coming to the hospital for several months with chest pains, etc., and no one finds anything, I'm thinking, oh, could this be POTS? Could this be dysautonomia? What should we do? How should we investigate them? I think all patients should probably have a blood count at least to just make sure that there's nothing else like anemia, because if you just have less blood, then that can typically cause similar symptoms of orthostatic intolerance. So a simple blood test to tell you that you're not anemic can be helpful. Electrolyte deficiencies, so that's important. Low potassium, low magnesium levels can contribute. I think every patient should have their B12 folate, iron levels checked, and virtually, I would say 90% of my patients with POTS are vitamin D deficient as well. I think if there are any symptoms to suggest that there may be an autoimmune condition like dry eyes, dry mouth, a rash, any other thing like that, then we would check autoantibodies. If you speak to the immunologist, they say check a serum tryptase to look for mast cell activation syndrome. Having said that, when you talk to mast cell experts, they say that's a notoriously poor test. So again, if you have members who've been told, oh, well, you don't have it because your tryptase is normal, I wouldn't go by that. And I think there are some really good experts who have more sophisticated tests that they can run to look for mast cell activation syndrome. I think it's worth just checking catecholamines. So a lot of people who are diagnosed with POTS will go through 24-hour urinary catecholamine collections, and that is largely to look for tumors that are secreting adrenaline. That's what you're looking for, that maybe it's not this condition called POTS, but it's a tumor sitting there releasing adrenaline, and that's why the patient's getting their symptoms. So I think it's a worthwhile thing to do, but generally the pickup is incredibly low. I don't think I've picked up a tumor secreting adrenaline in any patient that I've come across so far. Holter monitoring is something which allows us to see what is happening to their heart when they're getting the palpitation. Generally in POTS, what you would expect is to see the heart rate rise completely normally. So the rhythm is normal, but the heart starts going faster when they stand up. But once in a while, you will find patients who get this thing called a supraventricular tachycardia, where the heart goes fast because they've gone into an electrical disturbance. And it's useful to know this, not because this is a dangerous condition, but because this is a curable condition. If your heart rate shoots up because you've got a supraventricular tachycardia, then we can cure that once we've identified it by doing something called an ablation, and the heart rate won't go up. They can coexist, so you can have POTS and you can have supraventricular tachycardia. And if you treat the supraventricular tachycardia, it doesn't mean the POTS goes away, but it does mean that the patient may be able to stand for longer because they're not getting the supraventricular tachycardia. So that's the real utility of Holter monitoring in this setting. But then The diagnosis, the test that everyone does to try and make the diagnosis is this thing called tilt table testing. And tilt table testing involves lying the patient down, strapping them to a table, and then measuring their heart rate and their blood pressure in response to change in the level of tilting and in response to change in posture. And when you look at what should happen in healthy people, and this is telling you when you're tilting them and what happens to their blood pressure here and what happens to their heart rate. The heart rate goes up ever so slightly, but not hugely, and stays like that. The blood pressure doesn't really change very much. But if you look at a patient with POTS, the blood pressure doesn't change very much, but you see this rise in heart rate, and the heart rate stays much higher and then comes down when you tilt the patient backwards. The question is, how long do you need to tilt someone for to be able to see these changes? And the answer is that virtually within 3 minutes, the majority of patients will get their heart rate up. So at 3 minutes, the majority of patients will get, if you have POTS, your heart rate should shoot up excessively by about 3 minutes. By 7 minutes, virtually all patients tend to have demonstrated this rise, this excessive rise in heart rate. So that's how long you need to tilt them for. You don't need to tilt them for more than that. The problem is that when patients with POTS do have tilt table tests, it destroys them. It's a very, very difficult test for patients because A, it's very uncomfortable. And secondly, often it will knock patients off that stable course for months or weeks, after the tilt table test. Is it a necessary test? And I would argue it isn't. I don't think that the diagnosis is based on the test. I'm not here as a doctor to treat a test. I'm here as a doctor to treat my patient. And therefore, I would much rather listen to the patient and, regardless of the tilt table test, make the diagnosis. I happened to go to a conference a couple of years ago when I met Professor Gall in London, and he was doing a talk, and I asked him the question. I said, the problem with this is when you are making a diagnosis on the basis of a test, you have to first and foremost know how good the test is. And no one's done that work with tilt table testing. What you really want is you want to take a bunch of people who have POTS, or who you think have POTS. You want to put them through tilt table testing. You want to see how many come back positive, how many come back negative. And you then want to treat both groups as if they have POTS and see how many respond. And that will tell you how good your test is. But no one has done that work. So yes, a tilt table test may help you make the diagnosis, but does a negative tilt table test refute the diagnosis? And if you ask most experts now who deal with this, I would say 50% of patients who ultimately respond to the treatment for POTS will have a negative tilt table test. And this is the problem, that if you end up having a negative tilt table test, you're told you don't have it. And your search continues. You're left high and dry. Well, you don't have POTS, go away. Well, how does that work? So personally, I would say, well, okay, I do the test not because I don't believe the patient. I do the test to validate the patient, and I do the test to validate me. But if the test comes back negative and the patient sounds like that's what they've got and no one else has been able to offer an alternative explanation, then why wouldn't I want to get on and just try and treat and hope that something works for the patient? There are lots of disadvantages of a tilt table test. It's not easily available. It needs to be done in an experienced unit. It's very uncomfortable for the patient. If the patient takes medications, that may lower the diagnostic yield. But taking the patient off the medications risks upsetting the balance that you've managed to achieve. Ideally, it should be done in the morning because that's when the patient's symptoms are the worst. There's inadequate data on accuracy. Patients do have good days as well, and that and that's just very much the nature of the condition. It's not something you can do in pregnant women. And one of the groups of patients that really suffer are pediatric patients, because many centers don't do tilt table testing on children because they think, oh, we need pediatric support, etc. But these are children, who pediatricians don't get very interested. They can't come to see a cardiologist, an adult cardiologist, and they lose out on the most formative years of their lives, feeling miserable and just, they can't go to school, they can't hang out with their friends, for lack of anyone wanting to just get on and try and make a diagnosis. And this is a big problem with POTS. And I certainly, I'm an adult cardiologist, but to my mind, it just doesn't feel right that you've got kids out there who are suffering, whose moms have got POTS, but no one would acknowledge that the child may have exactly the same symptoms, but the mom can't get anyone to get interested in the child. So in my case, I just say, well, come along and we'll just do whatever we can. Because where else, what else do you do? How do you leave these young people who could be out there and enjoying themselves with their friends? How do you leave them feeling like, oh, well, you're just lightweight and you just need to get on with it and you're just anxious? And I think this is crazy. So this is a real unmet need. And I think as cardiologists, as POTS experts, we have to work with pediatricians, and we have to start saying to them that, let's work together. Let's try and get these kids some support. Now, how do you go about managing this condition? And the problem is that there is no one size that fits all. But in general, I think there are 4 prongs to trying to manage patients. The first and foremost thing is to understand and to accept what the patient tells you. I think to develop a rapport with the patient, to tell them that you believe them, to tell them that you understand the struggles, and to tell them that whilst you may not have all the answers, you're there to support them, is really, really important. I think it's important to educate patients, because a lot of patients have gained everything they have from doing Google searches, and inherently there are problems with that. So to be able to educate them and give them the knowledge that I know, and at the same time say to them that, look, I don't know everything, but if there's anyone else you find who knows more than me, then I'm very happy to work with them too, because this is about you. This is about getting you better. I think it's important to identify and withdraw exacerbating medications. So in terms of medications, things like medications that lower the blood pressure. Unfortunately, what happens in patients with POTS who have hyperadrenergic POTS is that when they stand up, their blood pressure goes up. Now, what will happen is they go to a GP. The first thing the GP does is, let's lower the blood pressure. Well, that makes their symptoms worse, because their blood pressure was not going up because they had high blood pressure. Their blood pressure was going up because they had too much adrenaline in their system. So that kind of thing makes things a lot worse. Often these people are given SNRIs because they're told they have anxiety. So they're given things like venlafaxine, duloxetine. SNRIs block the uptake of adrenaline. So you leave more adrenaline in the system. So those are medications that will worsen the tachycardia, will make things worse. Diuretics, same things. So there are tons of medications that can actually make symptoms worse, and sometimes taking them off those medications can help. I think diet plays a big role, because a lot of patients with POTS develop esophageal and gastric dysmotility. Remember, it's a disturbance in your flight and fight and your rest and digest. So a lot of patients with POTS will find that they just don't get stuff through. They get a lot of bloating, they get nausea, they get cramping, and they're constipated for days. In that sense, the things that seem to help is changes in diet. So a lot of people benefit from going gluten-free. Some people benefit from a low histamine diet. One of the things a lot of patients with POTS will complain of is they'll say, when I've had a big meal, my heart rate shoots up. I become dizzy. the thing that's happening there is they're getting a condition, they're getting something called splanchnic pooling. Splanchnic pooling means that all the blood accumulates around their stomach beds, which means that for the duration of that time, there's less blood in the bottle. There's less blood circulating around because the blood is collected around the stomach. So small meals, protein-rich meals, small regular meals, so 6 meals, a more ketogenic kind of diet, not crazy ketogenic, but just more protein, less simple carbs, less sugars, regular meals, small meals makes a big difference. Gluten-free makes a big difference. I think compression helps. Again, with compression, and I'll talk about compression in a second. You're squeezing the bottle, so you're allowing more blood to go to the brain. Sleep management, a lot of patients, virtually every patient with POTS finds that they don't sleep as well as they should. And when they don't sleep, their symptoms get a lot worse. So they really struggle. So if you can improve their sleep in some way, then that makes a huge difference to how they feel. Stress and pain management and exercise. Now, let me just talk you through these. I think it's important to tell patients this is not a dangerous condition. Despite the fact that it feels hideous, it doesn't actually shorten a patient's lifespan. But it is also important to accept that it is a debilitating condition and it has a huge impact on the quality of life of the patient. And it's important to have that conversation not only with the patient, but also with their husbands, partners, family members, because often patients face this struggle where they just feel rubbish and people around them don't necessarily believe them. I think it's important to say this is a chronic illness. I think it should be managed by a specialist in a multidisciplinary and holistic setting. I think you have to involve a dietitian, you have to involve physical therapists, etc. And all of these people should be talking to each other. And all the decisions have to be made in partnership with the patient. It is not a case of, oh, go and see a dietitian who you've never met, who will just give the standard therapies, standard advice, or go and see a physiotherapist. It's about having a team of people who are interested in the condition and, more importantly, interested in that patient with that condition. I think it's important for patients to understand that they do improve over time, but it's never a straight line. They zig and they zag, and often, they come with one condition, with one set of symptoms, and those set of symptoms get a bit better, but something else creeps up. But on the whole, patients tend to improve, and they do achieve acceptable quality of lives. I think it's important patients should be empowered to look for aggravating triggers and aggravating activities, and wherever it's possible, minimizing those triggers is helpful. As a POTS doctor, one of the most useful things I can do is be the patient's advocate, and I certainly try and do that. Where where you have a young person who's worried about their exams, but they just cannot do anything, they cannot function first thing in the morning, then as their doctor, I would want to write to the school and say, look, this person is very capable, they're very willing, but they have this condition. If you make small adjustments, they'll do the best that they can for you without compromising their health. And often you need a medical professional to take that initiative and give it like that to schools, employers, etc. And that's why I think that's another thing that I found, as a doctor, I wish there was this wonderful pill I could give every patient and just get them better. I can't. So, but I do think that doing things like that can help their lives. And so why not? As I said, these are all the medications that can exacerbate POTS. You can have this slideshow by all means. In terms of diet, as I say, we talked about diet, but I think it's important to fill the bottle up. You want to fill it up as much as possible. So you want to drink at least 3 liters of water a day, and perhaps more in hot weather. I think most people drink more, but they don't have enough salt. And the problem with that is that if you drink more and you don't have enough salt, then the water just goes out in the urine. And therefore it becomes really important to keep that water in the body by increasing your salt intake. A lot of people are worried that salt is bad. Salt is in this setting, salt is one of the best things that you can do because you're trying to improve the blood pressure, you're trying to increase fluid retention. For a lot of people, salt itself is unpalatable, so you can take slow salt tablets rather than just taking table salt, but also combining that with electrolytes, oral rehydration salts is good. I think magnesium supplementation is really helpful. 3/4 of the population are magnesium deficient. And I think it's important to correct any nutritional and vitamin deficiencies. In fact, a lot of people who've taken vitamin B supplementation have benefited. And I think it's important to avoid things like soda, caffeine, diuretics, alcohol, smoking wherever possible. And with regards to compression, compression has the effect of reducing pooling. It increases the amount of blood returning to the heart. Compression is a big problem because lots of people don't know how to get it. What you want to do is you want to acquire RALS class 2 stockings, class 2 or class 3 stockings. Some can be bought commercially, but the GPs can prescribe these as well. And ideally, you want to compress up to as high as you can. So the higher you compress, if you go all the way there, you have a much more effective return compared to just there. So if you can get stockings which go to above the waist or can be combined with a waist attachment, or even these things called magic pants, then that can help push, improve symptoms. A lot of people struggle to know where to get measured. The best place to get measured is a lymphedema clinic because they do it all the time. So if you have a local lymphedema clinic, they can measure you out. And then with those measurements, you can either buy them commercially or get them from your GP. Now, virtually all patients with POTS have disturbed sleep, and that contributes in a big way to fatigue. Now, why is that? Why do they have disturbed sleep? There's a very interesting guy called Professor Alan Pokinky. If you ever get a chance, he's done a ton online, and he's a sleep doctor. And what he has noticed is that those people who don't sleep well, if you measure their adrenaline levels, their waking periods seem to be coinciding with adrenaline surges. And what he has what he's saying is, or what he has said is that when we go into REM sleep and we have dreams or anything like that, or if there's any disturbance around us, because we're producing more adrenaline, because the patients with POTS are producing more adrenaline, and adrenaline is a hormone of arousal, the patient ends up waking up. So if a dog barks, two people are sleeping, in one person who doesn't have POTS, you get a tiny adrenaline rise, they don't notice. In a person with POTS, the same dog barks, you get a huge adrenaline rise, the patient wakes up. Often the patient will wake up with their heart pounding. Sometimes the patient may wake up, not realize they've woken up, and then go to sleep again and wake up when the next kind of stimulus comes along. So in that sense, it is important to try and work with sleep hygiene. It's important to keep all phones and things away from the bedroom where you're sleeping, so that there's no lights shining in the middle of the night, there's no noises. A lot of patients with POTS have pain, probably because of their joint hypermobility. And whilst we're very good at taking painkillers during the daytime, we don't necessarily concentrate on taking pain relief at night when we're sleeping, because our automatic assumption is I will be sleeping, so I won't experience pain. But pain can manifest with rise in adrenaline levels, and therefore taking painkillers at night before going to bed is a good thing. A lot of people ask me about sleeping tablets, whether that can improve sleep patterns. Sleeping tablets help you go to sleep. They don't help you maintain sleep. And for a lot of patients with POTS, it is the maintaining sleep that is the problem. Can you reduce the adrenaline surges in some way by taking something like beta blockers? And that's very interesting. And this guy, Alan Pokinky, that I was talking to you about, has tried that, where he's given a small dose of beta blocker at night in the hope that the beta blocker will blunt any adrenaline surges. And certainly those people seem to respond. Some of them seem to respond. Another thing that can be helpful is to sleep tilted. And the idea behind that is that when you're sleeping like this, when you're sleeping flat, then there's no blood, there's no surge of blood in the legs. So more blood goes to the kidneys. And because more blood goes to the kidneys think you're overhydrated. So they produce more urine and you wake up more dehydrated in the morning. If you sleep at an angle, then there's less blood going to the kidneys. So the kidneys don't produce as much urine overnight, and therefore you wake up more hydrated. And if you give this like a 3-month period, your body adjusts and you retain more fluid. So that's the idea behind sleeping tilted. And there is some evidence that that can be quite helpful in terms of increasing blood pressure, but it does take time. It isn't something that happens overnight. I think it's important also to say that there is a vicious cycle. When people don't sleep well, they feel more tired. When they feel more tired, they get more depressed. When they get more depressed, they experience more pain. And acting on every component of that cycle, the sleep, the fatigue, the depression, the pain, is important. Stress will make everything worse. And a lot of patients currently with POTS have said that they've felt better since the lockdown, because they're not so regimented. They don't have to get up as quickly. So working with employers to try and modify working schedules is important. And patients should be encouraged to embrace other holistic and alternative therapies that improve their quality of life. So I would always encourage my patients to see if an acupuncturist can help them, physiotherapy, yoga, all that kind of thing. With regards to exercise, now there is obviously a difference of opinion, I think, between chronic fatigue syndrome and in POTS. And I can't really talk for chronic fatigue syndrome because I have very little expertise. But in the POTS patients, the general feeling is that exercise helps conditioning. It should be gradual, and initially it should be non-upright. And then as you develop a regime, you can slowly build up to upright exercise with focus on resistance training and especially the lower limb muscles. And benefits tend to be seen after 4 to 6 weeks. And ideally, the exercise regime should be at least every other day for 30 minutes. The benefits can persist even after 3 months, but the patient has to continue doing it. Otherwise, the benefits tend to go away. This was an interesting study done by Benjamin Levine again. And basically what he was looking at is the physical component scores before training and after training. And you can see that there was this there was this quite marked increase in how people felt from their POTS after a 3-month training period. Similarly, their social functioning score also improved after 3 months of training. He called this protocol the Levine protocol, and that's the protocol that is generally recommended these days. He also showed that actually when you did this, you could increase the blood volume and the mass of the heart. So you can actually change the structure of the heart to allow it to accommodate more blood and to be able to pump more blood out with each heartbeat after a period of training. So exercise certainly for POTS is good and is encouraged, but it has to be done gradually. In terms of management, one of the things to say is there are medications that can help. All these medications are off license, so they're not specifically licensed for this. And one of the problems is that because they're off license, there's a reluctance. Doctors are reluctant to prescribe them. Doctors want evidence. They want someone to go and say, oh, it's okay to prescribe it. And no one's going to say that unless there's big evidence. Well, to my mind, how are you going to get big evidence if you're not going to acknowledge the patients? If you're not going to even recognize that these patients exist, how are you going to develop the big evidence? How are you going to develop evidence with the medications if you're not going to use the medications? We cannot wait for 20 years for someone to come along and start funding a study. These people are suffering now. So in my own mind, I say to the patient, these are off-license medications, but here are some studies which have been shown to help and actually not harm. Do you want to try them out? And more often than not, patients will say, yes, I want to do anything that makes me feel better. And so I'm very proactive with prescribing medications, if the patient wants them, based on small-scale studies, because this is the way I'm going to develop a database of experience with these medications. So in terms of medications, there are two types. There are medications that help you retain more fluid in some way by either increasing the amount of water in the bottle or making the bottle smaller. And then there are medications that reduce the heart rate. So in terms of medications that make more volume or make the body smaller, we use something called fludrocortisone, which is an aldosterone analog, helps you retain more water. It's generally well tolerated. It can cause high blood pressure in patients, but generally this is not such a big problem in patients with POTS because often their blood pressure tends to teeter around the lower range. It can sometimes cause fatigue, nausea, headaches, and even edema, swelling of their legs because of the retention. That edema is one of the main reasons people don't like taking it. But otherwise, for some patients, it makes a huge difference. Another medication that we use is desmopressin. Desmopressin is a spray. I use it as a spray. Desmopressin historically used to be given to bedwetters, right? So the idea was you squirt this thing in their nose and they wouldn't wet the bed because they would retain the fluid in their bloodstream. It's a short-acting thing. It works very quickly. It works for about 4 hours, and it's often used as a special occasion drug. So once a week, if a person is facing a day of having to stand up at work or something, they can squirt this in their nose, and hopefully, if it works, it should give them get up and go for the whole day, or for at least 4 hours of that day. As I can show you here, the studies are very small. You know, this guy Satish Raj, he did it on 8 patients. So this is where the problems are. But in my own experience, I found that whilst a lot of patients don't tolerate it, the patients who do tolerate it find it to be something that really makes their quality of life better. There is another medication called erythropoietin. Erythropoietin increases the amount of blood cells in our body. It increases the blood cell volume. It's a very costly medication. It's given subcutaneously. And the big problem with it is it can cause blood clots. I've never used it myself, but this is something that is purported to be another treatment option. But I've never really used it because it requires subcutaneous administration and the risk, obviously, of causing blood clots. But I do use, let me just tell you about this, I do use something called midodrine. Midodrine is another medication, which is a medication which reduces the stretchability of our blood vessels. So because the blood vessels don't stretch as much, when people stand up, there's less room for the blood to accumulate in the legs. And that supposedly is that seems to help a lot of patients as well. I do use it in children as well as in adults. One of the big problems with midodrine, however, is that because it makes all the blood vessels a bit tighter, it can cause high blood pressure when the patient is lying down. And therefore, we don't give it for 4 hours before the patient lies down or goes to sleep, but we do use it during the daytime. One of the problems we face is that a lot of patients with POTS can't be up on their feet for a prolonged period of time anyway, so they're lying down most of the day, in which case it doesn't necessarily serve their purpose to take something like that. But in those people who are able to take it, it does help. So those are the kind of medications that will actually either increase volume or make the body smaller, so whatever volume you have is more effective. But then there are medications that reduce the heart rate. In terms of medications, the commonest medication that is prescribed are beta blockers, propranolol, and beta blockers do reduce the heart rate, but they also have a bunch of other side effects like causing fatigue, causing the blood pressure to drop. So most patients I've come across don't seem to tolerate beta blockers as well. Interestingly, there was a study, again by Benjamin Levine, comparing exercise training with beta blockers. And what he found was that actually, when you look at beta blockers compared to exercise training, the heart rate comes down with beta blockers and it comes down with exercise training, but when you look at the physical functioning score, how the patient responds, how they say they're functioning, exercise training, their physical function improves, their social function improves. With beta blockers, those things don't improve. So you reduce the heart rate, but you don't necessarily make the patient feel better, whereas exercise does do that. A much better agent, in my experience, is something called ivabradine. Ivabradine is a medication which purely acts on the heart rate. It doesn't affect the blood pressure. And that is my kind of go-to drug whenever someone comes to me with symptoms of POTS, because it lowers the heart rate and does so very effectively without giving the patient any side effects. But again, the data around ivabradine is very small, but anecdotally, it does help 70% of my patients. Let me just talk you through anything else. Another thing that can sometimes help is intravenous saline, and this idea that actually you just go on and put some more water in the bottle. Very effective when it is given. The problem is that the beneficial effects don't last very long. So within 24 hours, the patient goes back to feeling like they do. And so people have said, well, can we not just give intravenous saline chronically, continuously? And the problem with that is there are no easy ways to do that, because either you'd have to give the saline through peripheral cannulae, which block off, or you would have to put in a port. And the problem with that is that there is a substantially higher risk of causing blood clots. And there are no centers that I'm aware of that do this, and therefore it's not recommended. But as an idea that if you can just put fluid into the person, it works really well. And for those people who do get intravenous fluid, they just think, oh my God, a cloud has been lifted over my head. You know. There are other medications. There are medications. One of them is clonidine. Clonidine is something which acts against adrenaline. It's used also as a blood pressure lowering agent for some reason, but it does work, but very poorly tolerated. There's another medication called methyl-dopa. I have no experience at all with these medications, but these are other medications that are on the horizon. Some people use them, but I think in no ways have I found that there's any literature to say that these are more effective than what we do anyway. This is a particularly interesting medication called mestinon, pyridostigmine. Mestinon is an acetylcholinesterase inhibitor. So as I was telling you, you have a disturbance between your flight and fight and your rest and digest. And all the medications I've talked to you about so far are medications that are basically trying to blunt the effects of adrenaline. Mestinon works on the other side, and it starts improving your vagal hormones, so your rest and digest hormones. It's a little bit like having a screaming child in your house, and beta blockers and everything else is like saying, okay, you're not allowed to scream any louder. But mestinon's a little bit like that nourishment that a mother gives, and she gives the child a cuddle and makes him feel loved and all that, and he stops screaming. So mestinon is a really interesting medication. It reduces the heart rate. It is exceptionally good for gut motility in patients with gastroparesis, gut dysmotility. And lots of people tolerate it very well. And for some people, it has been a complete game changer. They come back and they say, well, I can function. I'm amazed. It doesn't work in everyone. 60% of patients get better with it, but it's another medication to think of. And then there's something called droxidopa. Again, these are supposedly reduce dizziness and fatigue. One of the things which is a real problem and no one knows how to deal with in POTS is brain fog, this idea of just cognitive dysfunction. And there is this medication called modafinil, which is a psychostimulant, which has been shown to actually improve brain fog. The problem with stimulants is that, yes, they can improve brain fog, but they may make all the other things worse, because you've already got too much adrenaline in the system, and you add in a stimulant, you would make things worse for the patient. But all the research points out that modafinil actually does work as a stimulant, but it doesn't make the POTS bit worse, but it makes the brain fog better. So in conclusion, what I'd like to say is that, I think now that we are becoming aware of this condition and there is some expertise, patients should not hesitate to go out there and ask to go and see someone if they think that they have their symptoms. They should not be put off by perhaps well-meaning but poorly informed doctors that they don't have it. I think it's worth going and seeing someone who has an interest in that condition. I think with treatment, 70 to 80% of patients improve uh, and return to an acceptable level of functioning. As I say, POTS patients have been and continue to be neglected by the medical profession, but things are changing. And I think raising awareness and working in partnership with healthcare providers will improve understanding and will allow us to have, hopefully, gain expertise in more treatments. And this is the way we're going to get there. Ultimately, I think, as I say, it's a remarkable condition that affects remarkable people. And a lot of these people find strength and resilience in the most terrible, debilitating state. And it is the remarkability of these people that will allow us to try and beat this condition. So thank you so much. I can't hear it. I can see people clapping, but I can't hear anything. So you can unmute yourselves. And if you have any questions, I'd be delighted to answer.
Thank you so much, Dr. Gupta. That's an incredibly thorough tour of the whole field, which has been absolutely fascinating. I'm wondering if you want to stop. That's it, lovely. And then we'll come back to the whole group. I'm going to manage the questions through the chair, just because that's the most efficient way of managing time. And but people have given me, I've got pages of them here, and I've been trying to check whether they've been answered as you've gone through. And fortunately, you have covered many things. There's a few ideas I just wanted to pick up, which is about the differential diagnosis of POTS versus ME/CFS. You know, the symptomology is so similar and it's so different, and that perhaps also leads into this whole thing about, you know, GPs seem to be now willing to diagnose people as having CFS, but they really seem to be still so ill-informed and unable to access the sorts of science that you've just talked to us about in terms of POTS and some of the things that you know, some of the other symptomology that might be going on for people. So there's one particular question, which is like, how do you talk to your GP when they're just not well informed? And you may have CFS, you may also have POTS, you may have other things going on as well, fibromyalgia, long COVID, or whatever. But you know, how should you approach your GP? Because I looked yesterday on the POTS UK website, and there was about a dozen specialists around the country who say that they have an interest and something to offer in terms of POTS. That is very few. So it's considered to be a rare disease, but certainly the medical response to it is rare.
I think you're right. And in my experience, even though there are doctors who have an interest in POTS, what you have to be interested in is in the patient. You have to be interested in patients, right? Again, my aim is not, oh, if you don't have POTS, I'm not interested in you. You know, my aim is whatever it is. My problem now is that because to a man with a hammer, everything is a nail. So I often worry that everyone who comes to me gets diagnosed with POTS, and maybe I'm diagnosing it too much. But I know that the treatments are not hideously dangerous. And I'm very happy to be guided by the patient. So there are times when someone comes along and they say, you know, maybe I've got the diagnosis wrong. So I would treat them. And if they come back and they say, look, I'm better. And I think, well, great. You know, that's what my ultimate aim was, not to try and work out whether I was right or wrong. My ultimate aim was to try and make the patient have some kind of quality of life. So wherever there is any kind of dilemma, I truly believe that it's worth just going for it and trying to treat the patient, or making those things available to the patient that they can choose to try out. in terms of where you go with the GPs, this is a really difficult scenario, but there are now major societies which recognize this condition. So the Canadian Cardiovascular Society has a position statement on POTS. The Heart Rhythm Society has this condition. So there are august bodies around the world that are now beginning to believe that this is a real thing. And they have defined it in some ways. And so being informed and being able to carry that literature and showing that to them and saying, look, you know, I was looking at this and this is what this says, and I think I've got all this, and here is someone who can potentially help me. What do you think? I think that would be a very compelling argument, and I can't see how someone will turn around and say, oh, well, it doesn't exist then, because here is a learned body stating that this is something that does exist.
Okay. It'd certainly be helpful either for our group or with your support to produce a kind of little pack or an argument to give to a GP. I think the other obstacles, which I don't know whether other people here would echo, but is that GPs are so unwilling to prescribe things that are offline, that what they want is this kind of somebody behind them who says it's okay. So they want the hand-holding relationship. And I was wondering whether either you or anybody else in the country does this kind of partnering with GPs, whereby you know, the GP is actually doing the prescribing, but you're able to provide a letter of support saying this appears to be a wise thing to do in this scenario. These are the risks. The patient needs to know the risks, but it's worth trying. Is that something you're ever able to do?
Yeah, I do. Okay. I mean, I often GPs would say, could you prescribe the initial doses? Yeah. And then we'd be happy to take on the thing. To my mind, it's a very simple, straightforward argument. This is not a dangerous condition. All you're doing is to try and make the patient feel better. Mm. If the patient comes back after trying what you've given them and said, look, I don't feel worse, and actually I feel better, and they haven't said that for the last 10 years, then I think there's all the reason to go for it. And so a lot of GPs do see that. They see that actually this person seems to have responded. So doctors are developing that confidence. But where the doctors don't have the confidence, they'll write to me and say, we're not comfortable doing this. In which case, what I would do is I do the prescriptions and send them to the patient every month, or which is hard work, but you know, if something is suiting the patient, the last thing, it is unacceptable to me that a patient should continue to suffer because someone is not willing to put themselves out of their comfort zone. That is, I absolutely, it is against everything I believe in, that if I cannot be bothered to put myself out of my comfort zone for my patient, then there's no point in me doing what I'm doing. So, you know, you have to do things, and if hopefully nothing ever will go wrong, but if there's something, then that at least I have my conscience, and I have the fact that I'm doing it, and I have the patient on my side. You see, that is really important, to have the patient on your side, for the patient to truly believe that you're trying to do something to help them with no ulterior motive, and so communication is so essential, this idea of making people understand that you're on their side, and you don't know what the answer is. But instead of them having to fight it on their own, they now have someone besides them. It's really interesting. I'll give you an example of the kind of thing that happened. I have a young girl with POTS whose mother today, she rang me. Her mother has terminal cancer, and she has to go to Guernsey. Now, the problem is they can't let her go to Guernsey unless she gets a vaccine. So she goes to the GP and says, look, can you not on compassionate grounds give me this vaccine so that I can go and see my mother? And the GP says, well, I appreciate that, but we can't make a precedent. To my mind, that I cannot believe that. Isn't that exactly what is wrong in making a precedent of compassion? What is wrong in stepping out of your comfort zone for the patient? Isn't that what we should be doing? How can we say, so this is where a POTS doctor, I think, or a caring doctor comes in, because he would say, no, I will say to them that I think you've got a condition that needs you to get the vaccine so that you can get on. this so that you can go. That simple thing will do more for her mental state, to be able to go and spend that time with her mother while she's dying, than any other medication I can give her.
So you're getting a very positive response from the chat on that. I think we would, we would love to take that quote about compassion and stepping outside your comfort zone and put it on every GP's office in the country. And certainly the ME and fibromyalgia community need that sort of advocacy on their behalf. I'm going to ask a few more general questions, but just following that on with one very specific one. Quite a few people with ME/CFS are prescribed with amitriptyline, particularly as something that potentially aids sleep, usually very low dose. So there's a question, I haven't noted who's asked it, but is there any sort of contraindications about amitriptyline and POTS?
I mean, I don't think there's an absolute contraindication with any sort of thing, you know. So there are patients, for example, monoamine oxidase inhibitors can make the POTS worse. And so can tricyclic antidepressants, but at high doses. So the first thing I would say is, even though I said that about the venlafaxine and the duloxetine and the fact that, you know, if the patient says to me, look, when I come off it, my mental health suffers, I'd say, well, go back on it. You are what matters, not my thing. You're what matters. No numbers matter, no diagnosis matters. What matters is you. And you're a physical being, but you're a human. Your mental health is important. And if this makes you better, then that's okay too. I'm here. I'm here to support you. You know, nothing is right or wrong. This is all about you and what works for you. So I wouldn't automatically stop people if they came in on an antidepressant or amitriptyline or anything like that. But if they came to me and said, you know, since I started this, I think I'm worse, then I would say, well, maybe what you could do is talk to your doctor about trying to come off it and seeing whether you feel better. And if you don't, you can go back on it, if provided you feel it's doing something good for you in some other way.
Okay, so it's the patient-centered medicine approach, which is key here. Yeah, one of the probably more sort of challenging bits of your talk has always been this whole issue about exercise. So the ME/CFS community has been, as you will know from the NICE guidelines around ME/CFS, if you've had a chance to read them, the most recent draft that's been issued is very clear that graded exercise is not something that should be recommended to people with ME/CFS. And yet it definitely is something that you've demonstrated some evidence that it really helps people with POTS. What is the way through it? And I guess what we're kind of thinking of is horizontal exercise. So exercise that doesn't tip you, and doing, you know, is that a way forward? Because we, you know, certainly we've always encouraged people to do as much exercise as you can get away with in your energy envelope. Absolutely. So it's not no exercise, it's just do as much as you can without triggering post-exertional malaise. But yes, is horizontal exercise useful?
I think so. I mean, I think the big problem is where deconditioning is bad. There is absolutely no doubt about that. Deconditioning is bad. So I think anything that a person can do to try and avoid deconditioning, I don't think it necessarily means that you have to go outside outside your comfort zone to do things. But it is important still to try and do a little bit of something within that envelope, as you put it, every day. I think it is good for our mental health. I think it's good for our muscles and our physical health. I think it's good for our immunity. So it's a very tough one. I asked this question at the POTS masterclass a couple of years ago, and no one had an answer. And I said, how do I know, you know, what is right? But what I do definitely know is deconditioning is bad, regardless of what the diagnosis is. So wherever possible, I would say horizontal exercise, even things like just squeezing a pillow between your legs several times a day, that kind of thing is good, you know. So yeah, I think that's what I would say. Being bedbound, I think, worsens the problem wherever possible. But yeah, you don't have to do, you shouldn't do something which just makes you feel completely awful in the hope that in
Yep.
some,
Yeah. I mean, maybe it's something we could pick up on our website forum that we want to get going. Would be to share ideas of so Kit's just put one in the chat about the Pilates classes, but share ideas about the kind of exercise that people who are really incapacitated through ME POTS or whatever, but do manage to find achievable without putting particular pressure on them. We had a couple of questions right at the beginning, which was all about the this thing about the variation through the day. Is that, and you kind of certainly seem to imply that mornings are generally worse for people, and things improve as the day goes on. Is that if you're a bit more upright? Does that apply to people who are pretty horizontal anyway, or is that a kind of
I think it's the
cortisol thing, or?
Yeah, I think it's the dehydration from the night before that contributes.
Okay.
So the fact that you're dehydrated, ironically, I mean, I think it's the standing up after the night that is the issue. So if you're bedbound continuously, I don't know whether it's so much of an issue. Of course, people do get surges after meals as well. So if they have a big meal, they'll get the same kind of thing. Yeah, I think
so dehydration being something to really think about.
Dehydration is absolutely, so
rehydrating before you stand up.
So I definitely recommend that. I would say to most people, before you get out of bed, take a jug of water, some electrolytes, etc. With all this, with this kind of thing I talked about, the more, because the pivot has moved this way, the more the swings, the more the pivot continues to move this way. So if you can minimize the swings wherever possible, the pivot starts moving back. So again, the idea that actually, yes, it is part of the condition that your heart rate would go up, but wherever you can avoid it, wherever you can reduce that by doing something beforehand, it's good. Because that adrenaline stays in the body, it does tire you out.
Okay. We're inevitably going to mention COVID. Two things really, which is, have you begun to notice any correlation between POTS and long COVID in particular? And secondly, could you just say anything about the vaccine? Whether there's any problems?
Things I would say. Number one, we are beginning to see a lot of, 10% of patients with, COVID then develop this kind of constellation of unusual symptoms that goes on for a few months afterwards, brain fog, tiredness, etc. Question is, why those 10%? Do they have a genetic vulnerability that has been brought out by the virus, or is it just the virus? I don't know. In those patients I've seen, again, the same things apply. I tell them to keep really well hydrated. Wherever patients complain of dizziness, to my mind, dizziness is a lack of blood to the brain. So if you can increase the volume in the body, that seems to help. The patients who have gotten better with their brain fog, etc., are the patients who've said, yes, when I increase my salt, when I increase my water, when I increase my electrolytes, that made a difference. Concentrating on sleep, regular, again, slow exercise, graded exercise helps in a big way. I wonder whether this is something that has brought about, that has just pushed, that maybe some people were carrying a vulnerability, and again, being hit by the virus has just brought that vulnerability out. They certainly don't seem to be as badly affected as people who get EBV or glandular fever, because it seems that those patients who have vulnerability and get glandular fever get really unwell. With regards to the vaccine, the big risk from the virus tends to be in people who are older, and by the majority of patients that I come across with POTS, etc., tend to be relatively younger. So they are generally people who, although they're debilitated, they're unlikely to come to a huge amount of harm from the virus itself. However, having the virus could undo all the good work that they've done with medications, conditioning, etc. So I now write to my patients and my GP and the GPs, and I say, well, I think that's really important. I think the fact that here is a person who's finally beginning to see the light at the end of the tunnel, and and if they get the virus, then that may knock them out, and that may set them back, you know, so many years. So I think you should think about prioritizing them. So I say that, um, even though it doesn't necessarily meet the criteria. But I suppose perhaps that's one advantage of having a condition no one knows about. If you've got a doctor who's on your side, then he can just add his weight and everyone will just listen because they don't know enough about the condition. So that's what I try and do. So I normally write to their GPs and say, look, you know, work with the patient, work with the patient. They've got, it's a hard enough life anyway. Come on, let's try and make it a bit easier after so many years of struggling.
And any comments on the different sorts of vaccine, or is that too detailed?
No, I don't have enough insight into the. I mean, no, not really. Again, we don't know. The only thing I would say is that the vaccines have only been around for a very short time, and we don't know what the long-term consequences are, if there are any. Who knows? So at this point in time, I think it's what gives you peace of mind as someone who's a patient. If you feel that you're already, you know, you're more socially isolated because of the virus, then for mental health, it is good to be able to go out and do the things you want to, etc. So I work with the patient and go by what the patient wants. If a patient comes to me and says, I really think I need this, then I support them. But I have no real insight into which vaccine is better.
Okay. There was a question right at the beginning from Melissa, which is, do people fully recover from POTS?
I have a few patients who've come back and said to me that I think I can go back to work, and they go back to an acceptable level of functioning. And I also think that no one I have is just terrible all the time. I think people sort of have flare-ups when they're particularly low, and then they get better. My problem is I only see them when they're particularly low because that's when they contact me. So, but all the times when I'm not seeing them, many of them are actually doing okay, and then something else happens. So it's not all doom and gloom. It's not that you're stuck and you will only ever just get worse. You will still go through good phases and bad phases. But I think to stay at a good phase requires a bit of work. So the people who are really invested, you know, who are exercising every day, who are really paying attention, who are managing themselves, who recognize when they need to lie down, etc., they go and they maintain the quality of life that they want or that they expected. I have very few people who've come back and said, I'm cured forever. I've not got anyone like that. But I do have lots of people. I have young girls. There was a girl who was wheelchair bound for 12 years. And she's now playing tennis and she's running around, and you know, she's had a baby. She's gone back to university. She works really hard. She makes sure she takes regular precautions, but she's achieving those things that she never thought she could have achieved. And I think that for me as a doctor is hugely seeing someone I've worked with flourish, and to be able to celebrate with them when they achieve these kind of little gains, you know, these little victories in their lives, is hugely satisfying.
Okay. There's quite a lot of kind of detailed questions really about comorbidities, and particularly people with other forms of orthostatic intolerance, not necessarily POTS. I think you've probably covered most of that in the talk. I'm not sure if there's anything else that would be particularly useful to add at this point for people.
I think it's important again to say that POTS is one face of this beast called dysautonomia. Orthostatic intolerance, vasovagal syncope, all those are different faces, but they all, when you ask them, you know, they all will say the same things. They'll all have sleep disturbance, they'll all have brain fog, etc., which is really interesting, because if it's not POTS, it doesn't mean it's any less troublesome for the patient. It's just with POTS, the heart rate seems to go up and the blood pressure doesn't fall. With other conditions, the blood pressure falls and the heart rate goes up in response to that.
Okay. And there's a couple of odd questions come up about, sorry, they're not odd, they're particular questions that come up about coffee, gluten sensitivity, any thoughts on any of those particular sort of dietetic things?
Yeah, I mean, I think when I didn't know about gluten sensitivity, and I did a survey I have with my patients, and I think 2 to 1 people said when they went gluten-free, they felt better. So 60% felt better. Now that's not everyone, and therefore, again, I would encourage people to try and work out whether that is them or not. I.e., you go gluten-free, and if you don't notice a difference, and if you miss your food, then go back. Similarly with coffee, I don't think there's a kind of cookie cutter approach to this. I would say, again, coffee can make things worse. If you're drinking tons of coffee, try and reduce your coffee intake and see whether that makes a difference. And if it makes a difference, great, keep going. If it doesn't, and you really enjoy your coffee, then go for it.
Mm-hmm. Okay. So in terms of getting our GPs much more up to speed, are you part of any training program? Do you
No.
What is there? What would a GP know about POTS? Would they know anything?
Unfortunately, not very much.
Yeah.
Unfortunately, not very much. But this is where I would love, I would very much welcome people who are interested in coming and spending time developing a database. I have about 400 patients now, but because we're always working, we never have the time to use that to start inviting people to say, look, we have a cohort of this many patients. How about you bringing your research and offering it to my patients? How about us using our patients and maybe interviewing them and developing literature surrounding their experiences? How about using patients who have gotten better to educate other patients? How do we develop all that? Do we work in partnership now to try and get the message far and wide? That's what we need. Unfortunately, in my case, for example, it's very tough to find that time to be able to do that. But that's what I think is the natural progression, where now we've got 500 patients, 400 patients. The biggest studies with POTS are with 30 patients. Why can't we get people to bring in the funding and let's get on and do bigger studies so that people can then have the data to give them that confidence to be able to do it, right? That was my plan. My aim was to get a huge cohort of patients. My aim was to try all these medications that no one wants to try out on them. My aim was to sort of document their experiences and then use that as evidence, as pilot data to get bigger research studies, draw bigger funding, etc. The problem is it's very difficult. So that's where we need support. That's where I would invite anyone who wants to do their thesis or their research. I would love for someone to come and do that work. The patient would love to do that.
So it sounds like that's the model of advocacy and demands for research that's been happening within the ME/CFS community also needs to happen in the field of POTS as well. I'm wondering, because time is moving on and we're heading towards nearly 2 hours, which is quite a long talk for us. There was a nice general question, which is, what is the most important thing you'd tell a person with POTS?
The most important thing is, the most important thing to say to them is that you're not alone. There are lots like you, and there are people out there who believe you and who are there to support you. And I think it's really, really important to understand that. And whatever it is, you're not alone. That I think, and validating the patient is by far the most important thing. I think for the patient to believe that they've been listened to, and for the patient to believe that there is someone on their side, someone who will work with them, I think that's more important than anything else.
I think that's an absolutely brilliant way to end, because that's one of the things that people in the ME/CFS community have felt has been so denied to them for so long, and the same with fibromyalgia, the same with many of these particular conditions. So it's an absolute honour and privilege for us to have you and your time on a Saturday afternoon, and I'm very grateful to you for that. And it's a delight really that your whole ethos and value system about practicing is based on listening to patients. And goodness, I think everybody here would thoroughly applaud that. So can I say a huge thank you to Dr. Gupta for an absolutely fascinating talk. We've had masses of information in there, and we're going to be able to share the slides, is that right?
Yes, absolutely.
Yeah, we can put the slides up on our website. The recording of the talk will be up on our website. It's Saturday afternoon, so don't expect it till at least the beginning of next week. And a big thank you to the team in the background, to Carol for setting the talk up, to Simon, Eliane and Sian, and thank you so much to everybody for joining us from all over the place. So the chat has got all these interesting places in there. So thank you so much, Dr. Gupta. Really, really enjoyed today.
Thank you so much for having me. Thank you.
Thank you.
Take care. Bye.